Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, ladies and gentlemen. Welcome to IROS room. It is always a happy day when we are joined by colleagues, our members, radiation oncologists of IROS from all over Indonesia, and also fellow radiation oncologists from other countries. And today we are extremely grateful to be joined also from many other disciplines, and even also survivors, volunteers, and many of our respected fellows from civil societies. As of today, we will learn and discuss together on a very important topic, palliative care, which is also one of the central highlights in cancer treatment. So a very warm welcome to our speakers for today, Dr. Ilbawi from WHO Geneva. Good morning to you. And Dr. Sandra Turner in Sydney. Good afternoon, Doctor. It is a pleasure to have you here today. And also our respected expert panelists. Thank you very much for joining us today. So this is our first webinar in the palliative series that we plan to do continually this year. So we hope that not just today, but we will continue to see you again in the next series also, and even invite more of your colleagues to join in the coming webinars. And so now, without further ado, to open our session today, I would like to invite our president, the president of IROS, Professor Soehartati Gondhowiardjo, Prof. Tati, to please give the opening remarks. Please, Prof.
Yeah, thank you very much, Dr. Mayang. So, Assalamualaikum warahmatullahi wabarakatuh. Salam sejahtera, salam sehat untuk kita semua. Good afternoon, good morning, ladies and gentlemen, my fellow colleague in Indonesia and surrounding. It's always a pleasure to welcome everyone in our IROS webinar. This year, we IROS are moving forward with a new series of webinar, which is a very important topic, the palliative care, especially in cancer, of course. As you may have noticed, palliative care, palliative treatment, including its relevance and important in cancer care, have been the highlight of many discussions and events. Therefore, we can see that the global attention has come to this topic, including from the WHO, as well as from the IAEA, International Atomic Energy Agency, with a special program running right now. And this meeting today is a part of the national activities of that IAEA RAS 6098, and me as and Mayang as the national project coordinator. Here we have again Dr. Ilbawi, the focal person of cancer control in WHO Headquarter in Geneva, where we will hear from the global priorities, direction, and strategies in the palliative care in cancer. Thank you, Andre, for your time and expertise once again. One of the connected important points of palliative care is the multidiscipline participation. We know very well that cancer requires many colleagues from a lot of division, a lot of department disciplines. And as we from IROS, we would like to, of course, remind as well as to all our members, what is the role of radiation oncology in palliative care? And for that, we invite the respected Dr. Sandra Turner from Sydney. And she kindly once again agreed to support us in Indonesia. And she's an expert with 20 or more years of practice in radiation oncology, and also a leader in radiation oncology education globally. Thank you, Sandra. We really will learn a lot from you today. And as we all a part of a comprehensive cancer care, we have here our expert panelists. Dr. Nuhonni, the most senior expert from the Palliative Society, Dr. Pryambodho, expert from the Anesthesiologist from the pain release, and Dr. Derajat, the expert from the surgical oncologist, Dr. Djumhana from the medical oncologist, and our own Dr. Ben from the IROS. I'm very proud to have these amazing colleagues of mine here, and I believe that the discussion will be beneficial for all of us. cancer burden will continue to rise. And therefore, the application of implementation of palliative care in cancer treatment has to be known well by all practitioners, especially who are working in the oncologist side. And that if it is well placed from the hospital and reaching until the community level, it can be very cost efficient and it can help a lot of patients everywhere. From today's discussion, we hope to recognize the same understanding of what is palliative in cancer treatment and key areas to be explored more in the next series that will benefit all of us from all disciplines. What are our roles? What we do really align with the palliative care goals? Are we doing enough already? There are many questions we need to think about and learn together, discuss and answer together. I hope that our session today will be another step of our work together, hand in hand, in improving palliative care for all of our patients. Please enjoy the session. Thank you very much. Thank you, everyone.
Thank you. Thank you very much, Prof. Tati. Now, before we begin, I would like to introduce the Zoom webinar features for all participants. We are using the Zoom webinar. So on the bottom of your screen, you can find the Q&A box. So you can click and type in your questions or comments at any time during this webinar. Please, if you can, also proceed with your name and institution or country. And then we can discuss it in the discussion session. And also at the interactive session, if you would like to speak or ask a question directly, you could also click the button raise hand, and then you can speak on your turn. And now before we move on to the speakers, let's take a group photo first in the panel room. Dr. Mahesa, if you could kindly guide us for the picture taking.
Yes, thank you, Dr. Mayang. I am Dr. Mahesa from the committee. Dear Professor and doctors, kindly turn on your camera and I will take your pictures. Okay, so I will take your picture twice. Please hold your pose so we can get clearer picture. 1, 2, 3.
Dr. Sri, can you on your camera, please? Okay.
Okay.
Okay, okay, I will begin taking your pictures. 1, 2, 3, smile. Okay, one more. 1, 2, 3, smile. Okay, thank you. Back to you, Dr. Maya.
Okay, thank you very much. And now let's move on to our first speaker for today. Dr. Andre Ilbawi is a medical doctor specialized and double board certified in surgical oncology. Dr. Ilbawi joined the World Health Organization, WHO, in 2015, and now serves as the acting technical lead for the cancer program at WHO headquarters in Geneva, Switzerland. So please, Dr. Andre, to begin your presentation.
Assalamu alaikum. Good afternoon, good morning, dear colleagues and friends. I would like to begin by saying thank you. This is such an important session to have, and what IROS, Professor Tati, Dr. Mayang, and our esteemed panelists are here to do is to share with you why palliative care is perhaps the soul of medicine, as we say. It is fundamental to how we care for our community, and it is perhaps the most important area of cancer that we can offer as part of comprehensive cancer control. This is easy to say, but it is not easy to deliver on. What IROS is doing, what you are doing by participating today, is showing a commitment to care for the most vulnerable at the most vulnerable times in their life. So thank you. It is a humble privilege for us at WHO to join, to discuss, and to reflect with you how can we in fact deliver on the palliative care agenda in cancer and beyond. For the next 30 minutes, this is what we will focus on. Where does palliative care fit in the global agenda? Then, where are we in the broad implementation of palliative care priorities? Where do we go from here? Let us begin with the global landscape of palliative care. Unfortunately, we must start with the difficult realities. Palliative care is only being achieved at the level of intense support that is required for 12% of the population. That means 9 in 10 people with cancer or other palliative care needs are not receiving effective palliative care. I don't want to say much more on this. You can imagine the consequences. Death while suffering symptoms that are being untreated, fear in the last moments of life. We can, and in fact, we must do more, because another way of presenting it is to share with you the millions of people who need palliative care today. This is not a problem that is getting smaller in scale. 57 million individuals need palliative care now, and that is up from 40 million now, only about 8 years ago. There are reasons to be optimistic. We see it as a political priority. Those receiving palliative care services has increased, but yet millions remain without it. So where do we go from here? As we heard Professor Tati wisely reflect, it is important to understand what is and what is not palliative care. You will see on the left side of the screen some definitions. And each of these aspects of the definitions have value or meaning. This is why, from WHO's definition of palliative care, it is important to understand this is not only about pain and relief. In fact, it is an approach that improves the quality of life of patients and their families. Why patients? Why their families? As an example, more than 40% of women with metastatic cervical cancer are abandoned by their intimate partner. How can palliative care improve the quality of life, not only for the individual, but for their families in the most vulnerable moments of their life? Second, this is about anyone who is facing a life-threatening illness. This is not for the last month of someone's life. This is not the last year of someone's life. What fundamentally the definition assumes is anyone who's facing a life-threatening illness from the moment that they're diagnosed with it. As you can see, in cancer, we are heavily focused on palliative care because it is one of the most common conditions that does require palliative care, given the life-threatening nature of the disease. It is also about prevention, not only about how do we relieve suffering, but how can we prevent it. Yet when we and the global community define what are some of the priorities that are needed in palliative care, we assume again it is only end of life and the relief of suffering. In fact, a large percentage of key health interventions require some dimension in the prevention and relief of suffering, almost 1/3 of all health interventions. And finally, what do we do beyond pain relief? Anxiety, psychosocial support, financial distress, loss of faith. This is happening in our community, and these are conditions or circumstances that we as health professionals can respond to. So the definition is broad and is intended to be broad to recognize the importance of caring beyond just the symptom relief, but the entire experience of someone who has a life-threatening illness. Historically, the conversation starts with health professionals, and again, we are so pleased to be joined by advocates and survivors. You are the ones that have driven the agenda forward. You are the ones that are in the rooms or in the homes of people who are dying from conditions like cancer. But in reality, we realize that it's more than just a person-to-person engagement. There's a community. There's a community of family members, community activists that are around that individual who need support. And then there are a network of professionals. As we will discuss later, palliative care is not just for the work of a specialist or an oncologist, but everyone. Nurses, community activists, volunteers, social workers, psychosocial oncologists. These are the people that will advance palliative care. But let us also remember it's the responsibility of governments and government agencies to advance palliative care as part of a human right. Let's pause on that thought for a moment. We often say health is a human right and palliative care is fundamental to it being a human right. Why does that matter? And in fact, is that reflected in the current political nature in which we work and live? The reality is it is a commitment that governments have made now for almost 100 years. Health is a human right, and within it, to ensure access to preventive, curative, and palliative health services. From day one, palliative care has been prioritized, and governments have committed to making it, again, a human right. At a national level, this can take a variety of interpretations and outputs. But most importantly, because it is a right guaranteed by international law and by extension, a commitment that governments have made, it is intended to increase accountability, to ensure that vulnerable populations are not discriminated against, and to ensure that all governments, legislators included, include these human rights in national legislation. We see it even more recently with the SDG, Sustainable Development Goals from the United Nations. In it, again, palliative health services are prioritized and are being monitored as part of the SDG targets. At WHO, we similarly have a mandate to prioritize palliative care now in 2014. What has this done? Well, if we look in detail, we can see some of the priorities that emerge because this is where governments tell us what to do and how to do it. Governments have committed to implementing policies to determine the needs, updating access to medicines, and training a workforce such as what we're seeing today. On the WHO side, we've been able to respond by producing a variety of guidance, which you can see also listed on the screen here. But most importantly, what this has done is to be an advocacy tool that has allowed different stakeholders to take up palliative care at the highest levels of governments and of international dialogue. So we have for us tools when we want to advocate for palliative care. We have human rights language, we have political commitments and declarations, we have targets, and now we have a resolution. But of course, that's not enough. So let's start again. As many of us know, when we classically talk about palliative care, you see a figure like what is on the screen now. What you see is morphine consumption per capita, and you can see where so many of the countries are organized. Those that often use the highest proportion of morphine or other opioids are those that have the largest size. And in some continents, the use and availability of pain medicine is almost entirely absent. We say this shows that palliative care is not available. But perhaps that's not really telling the full story. What about the broader system needs? What about the broader requirements to deliver palliative care? Do they exist and how do we build them? Let's look at the pathway. The pathway, in fact, doesn't start with the question of, is morphine available at the end of life? It is, in fact, starts with the question of, what are the palliative care services that we want to prioritize in our clinics, in our hospitals, in our national strategies? It is only once we've defined these priority interventions, we can look downstream and see, is palliative care available for populations? What interventions? The second question is, how do we organize services? Are these services at the community level, at hospitals, or at cancer centers? How do we train the right people? What we see is this cascade effect. Once we know what services should be prioritized, it helps us understand where do we build capacity, who needs to build capacity, that is, what workforce and what competencies. Then we can ensure the products are available and ultimately improve access to palliative care. So let's spend a bit more time dissecting out these three dimensions. What interventions, how do we organize services, and then how do we build capacity? Morphine availability, again, if we start here as a reference, in fact, in the past 10 years, we've seen increases in morphine in the majority of countries. But again, the increases have been only incremental. And when you compare high-income countries, which is the top line here, with low and lower middle-income countries, and even upper middle-income countries, you can see the big gap that exists. So it is time for us to look at the broader question of availability. Because for so long we focused on morphine as a community, did we lose the opportunity to improve primary healthcare-based palliative care or community and home-based palliative care? Although not a long interval, when we look between 2015 and 2019, we also now have 2021 data that is coming out. You can see we've seen little progress. So by focusing on morphine, yes, we can make progress, but in fact, we've seen minimal to no progress in the availability of the service itself. So let's dissect it out a bit further. What do we need to do to build this cascade? Defining priorities, organizing services, developing workforce competencies, and then ensuring that the products and ultimately the service are available. This is where we see inaction coming out. If we start with the question, is palliative care included in cancer control plans? Again, very few do, less than 40%. When we look at detail in these countries that do have palliative care, often it's just a tangential reference to this being an important priority, but no operational considerations. Similarly, if we look at the agenda and ask, in non-communicable diseases, is palliative care a priority and is it an operational priority? You can see, again, 40 to 50% of countries have taken this as a priority. So where do we go? Well, again, are we including palliative care as part of an essential health service package? What we did at WHO is we evaluated every country's benefit package. That is, for the most common insurance scheme in a country, what services are included, and we identified a few index services to use as a reference. In palliative care, we looked at 4. We can see our governments paying for or supporting access to morphine and other opioids. You can see here high-income countries, upper middle-income countries, even low and middle-income countries are in fact offering this service. But when we asked a few more of what would be considered essential palliative care, is home-based palliative care included? Is psychosocial and spiritual support being offered? Is inpatient hospice care even an opportunity? You can see in high-income countries it is, for all other countries it is not. So we are seeing that governments are not including these essential interventions as a priority, and this is where we have to shift our dialogue. Because if we focus only on morphine, only on limited elements of end-of-life care, we're missing opportunities to take on the broader care needs. Without funding, we can't go far. In NCDs, in cancer, we see palliative care is the most likely to be underfunded. So what again do we have to do? Starting with the broad concept that palliative care is about a multi-sectoral response. Here's an example of what that means. If we look, for example, at legislation that enables palliative care, and this is data from select high-income countries that are part of the OECD. If we ask, is palliative care services, as an example, leave for informal caregivers offered as part of the health strategy, you can see even in high-income countries, it is neglected. So it makes it difficult to offer palliative care at home, in clinics, when people and their informal caregivers who are supporting them are unable to receive the support that they need from a government. And this is not for a lack of asking. The vast majority of families around the world are seeking paid leave or some support for caregiving at end of life, yet the vast minority of countries offer it. So these are the challenges to think about as we draw up the global landscape of palliative care. Not only can we make sure that the medicine is available, but how do we create a better system response? The current challenges are listed on the left. Fragmented or absent national policies, insufficient or lack of funding, and activities that are limited to access to medicines. This doesn't have to be the case. We've seen governments, societies, advocates, professionals change the narrative by focusing on a broader approach, a multi-sectoral approach that brings on the specificities of palliative care that are needed for interventions to be delivered, for workforce to be trained, and ultimately for the services to be made available. So we've talked about the policies. We can, in fact, get palliative care into policies. We know that. But the next question becomes, who offers the service and where is it done? Palliative care is time intensive. We must recognize that reality. When we look at the number of participants who need palliative care, how many days that palliative care services may be available, you can see for most countries, we're talking about 20 or 30 intensive days of care. And this is spread out over months. So it is time intensive. When we look at who can offer that service, on the right side, you see the workforce density of palliative care providers, and this is from the Global Atlas of Palliative Care. There are huge deficits to have the workforce that are required. Thousands of providers globally and in most countries. So again, is there a workforce entry point that we can use? We know The closer palliative care is offered to home, that is either home-based or community-based palliative care, it is more impactful, it is more cost-effective, and it is also the preference of patients and their families. But can we ask palliative care services to be provided by primary care providers? Well, this is a challenge. In most low and middle income countries, the average primary care physician or primary care nurse has 3 to 4 minutes to see each individual patient. So it is a big ask for the workforce. The limitations are currently so profound to ask for these additional services to be delivered at primary care. Of course, we still must prioritize it, but we must acknowledge the reality that the workforce simply is already constrained. What about specialists? Similarly, in low and middle income countries, one oncology provider is often seeing 1,000 patients on their panel. This is true for medical oncologists, surgical oncologists, and in some circumstances, radiation oncologists as well. So adding on additional essential tasks like palliative care, while critically important, must also acknowledge the reality that the workforce is currently being stretched. And we know in this COVID era that the workforce is also experiencing burnout and has added responsibilities that make essential services like palliative care difficult to integrate fully into clinical practice. But of course, we can't stop there. It's about how we organize services at different levels of care. I know this slide will be difficult to read, but each of these tables represents a level of palliative care. Where is it offered? If we look at a home care team, these are the types of providers that are needed. Doctors, nurses, community health workers, volunteers, advocates. If we then look at community-based palliative care, in fact, it's often the same providers. How do we train the workforce, ensure the competencies are available, ensure that these tasks can be delivered, and also you can see the training requirements to do that. These are not big asks. And if we add on hospitals, yes, it is more people, added workforce intensity, but also responsibility. If we see palliative care as the responsibility of only one occupation, that misses the opportunity to ensure that palliative care is available for everyone. Developing the competencies to offer palliative care services, in fact, is everyone's responsibility, whether we are a palliative care specialist, an advocate, or a volunteer. The competencies and capabilities are not difficult to build in. We've seen this in study after study. It is about adoption, capacity building, and accountability. So in fact, everyone is responsible for palliative care services. How do we embed that in our national policies and our approach? So what are the steps forward? Well, let's start with the reality that we have a new era in palliative care. We have seen historically the champions of palliative care, those that work in hospice and those that have worked in communities to advance the cause of those that are suffering at the end of life. But now we have more. We have new data that reinforce that palliative care is cost saving. There are very few things in cancer, there are very few things in health more broadly that are in fact cost saving. And not only that, there are data emerging that when palliative care is integrated into oncologic care, outcomes are improved. Survival is greater. That is a incredibly unique aspect of palliative care. It is cost saving and it improves survival. So we have new messaging, we have new data that allow us to advocate for palliative care as a priority. We also see how important it is to enable individuals and communities. As shared earlier, we have the recognition that without palliative care, people are suffering profoundly. But emerging data are showing the enabling characteristics of palliative care that, for example, can improve adherence to care overall. It can support informal caregivers in returning to work. It can reduce the mental health costs of end-of-life care, both for the individual and for their family members. So we have the data now, not enough, but these are important messages to recognize and to build on as we advocate for palliative care at a global, at a national, and at a local levels. What more can we do? Well, to recognize that palliative care is our shared responsibility. Cancer, of course, is an important dimension of where palliative care should be focused, but we are not alone. We have taken a leadership role, and we see this again today. IROS has taken palliative care as a primary cause, and appropriately so. So in the cancer community, we have both the opportunity and in many ways the responsibility to advance palliative care as a health priority. But we are not alone. And identifying what types of other occupations can work alongside us is an important part of ensuring that services are not fragmented and that resources are optimized. More than 30 occupations are responsible for delivering palliative care, and this is something we should see again as an asset. And then finally, the current reality of COVID, of health emergencies globally, including the devastating effects of the pandemic, have reminded us that death without dignity is not acceptable. We've seen the horrific stories emerge in the pandemic, and this has helped everyone, high-income countries, governments, and low and middle-income countries recognize that without palliative care, we are not dignifying our societies and our communities. So we have a unique opportunity. But we as a community also have to understand what it is that we're advocating for. Here's an example as to why defining priority interventions is so important. We know, let's say, in a small city that there will be 1,000 individuals diagnosed with cancer each year. We can say half of them will require radiotherapy at some point, but that's not enough. We know that some of them will be for curative stage 1, stage 2, stage 3 disease, and some of them will be for palliation. If we look at those that could benefit from palliation, there's a variety of indications for which palliative radiotherapy is relevant, whether it's for cervical cancer, gastric cancer, breast cancer, or other. But what if we introduce the scarcity that exists in healthcare? And we say, while 500 can benefit, there's only enough capacity to care for 200. These are the unfortunate realities of how we define priorities in health, but it is not a measure to say that we must all suffer, but rather how do we ensure our resources, our capacities are optimized for quality of life and the services that are needed. What we then focus on is understanding that if there are limitations in capacity, we as a community must be the ones to first come out and say, we understand. We understand that someone with an advanced gastric cancer may not benefit or may have some benefit from radiation therapy at the end of life, but in fact, someone who has a bone met to the spine from breast cancer could in fact have a much greater impact and overall gain. So how do we ensure that we organize services and collectively define what the priorities are? Because once we've done this, we can also understand not that we're neglecting everyone, those that can't access radiation oncology, but that we can also identify what are the services that we can offer those other populations. This is multidisciplinary in nature. And in fact, as an example, myself being a cancer surgeon, can share with you that this is part and parcel of everyday clinical practice for a surgeon. Almost 1 out of 5 operations are palliative operations in the cancer community. That is a pretty striking number. But how do we establish those priorities? How do we communicate with patients? How do we deliver multidisciplinary care? And how do we balance the benefits and risks of end-of-life intervention so that the fundamental needs of those with cancer are being met? Here's where we need increased attention, increased multidisciplinary dialogue, and a stronger research agenda. The second is to realize that the bulk of palliative care is not to be delivered in a hospital. The vast majority of people with cancer prefer to be at home at the end of life. But we know in high-income countries, the opposite happens at great cost to the patient and their family and the quality of life that they were seeking. So how do we ensure that people are as close to home at the end of life? Here's again why organizing services are such an important priority. There are hospital services, there's community services, and there's home-based services. Who is going to do what? And this is the type of health system planning that will ensure that palliative care services are available. We must think big, we must be strategic, because offering palliative care only in hospitals misses the entire objective of palliative care, which is to provide that end-of-life support. But it does require coordination. Who will do what, at what level of care, and how do we build integrated systems? This is not impossible. We see governments delivering on this and increasingly focused on this concept of how to organize services. And this is in fact something we see in Indonesia. The government has also advanced. So each of us have a role at the table to say, here are the types of services, here are the competencies, and here's where we want them to be delivered as a foundation to more advanced health system planning and palliative care. At WHO, we have tools and resources to support this, either at the country level with some of our published material, as you can see here, and of course, through global dialogues. But at the end of the day, we are here together as a community to see palliative care not as an add-on in a cancer program, but as a fundamental human right for us in the cancer community and for health more broadly. Yes, it is a political choice. Yes, it does require government buy-in, but let us remember that we already have that. We have a human rights language that allows us to advocate for palliative care to be available for all. The current reality is devastating, we know that, but that is not a reason to give up. We know the importance of being there at the end of life and offering care when people are most vulnerable. Pain relief is important, but most importantly, what most individuals at the end of life are asking for is the support that they need to relieve all symptoms that often result in their suffering, and to do so in the comfort of their home with the support of their family. This is not easy. Multiple tools are needed: legislative, regulatory, professional, and competency buildings, and all of this does require the engagement and support of advocates at all levels. But we are committed. The number of people here today, the intensity of support in the palliative care community reminds us that we are all committed together. With the resolutions, guidelines, and initiatives we have, we can go so far. It is now a new opportunity. And thank you again to IROS, to those working in Indonesia at government level and at an advocate level to advance this moving forward. We can save lives, we can improve care, and most importantly, we can relieve suffering when people need it most. Thank you.
So thank you. Thank you very much, Dr. Andre, for such an eye-opening talk. It is very enlightening to hear that palliative care is all of us, all of our responsibilities. And if everyone is participating, involved in palliative care, so the gap of human resources needs will become much smaller, and we all have to do it together. So it's a great opportunity to have Dr. Andre here, and I once again encourage all participants, if you have any questions for Dr. Andre, you could just type it in the Q&A box anytime. So now we will move on to our next speaker. Yes, we are also very honored to have Dr. Sandra Turner here. Of course, many of us, all of us radiation oncologists are very familiar and look up to her expertise. Dr. Sandra Turner is a radiation oncologist based in Sydney, subspecializing in urological cancers and sarcoma. She is an associate professor at the University of Sydney. She is the lead of medical professional development in Western Sydney Local Health District and a member of the Faculty of Radiation Oncology Council of the Royal Australian and New Zealand College of Radiologists. She was also chair of the Education and Training Committee and lead examiner in radiation oncology in Australia and New Zealand for many years. She was founding lead on the Targeting Cancer campaign, raising awareness of radiation therapy amongst patients, carers, and other health professionals. Dr. Sandra has an ongoing passion for medical education and supporting the leadership development of all radiation oncology team members. So please, Dr. Sandra, you could begin your talk.
Thank you, Mayang. Can everybody see my slides okay?
Yes, it's perfect.
Yes, fantastic. And thank you to Professor Tati and to IROS for inviting me to be part of this very important webinar. I'm very impressed the focus that you're putting on palliative radiation therapy, and the number of people that have signed up to be involved is absolutely incredible. So thank you for the privilege. And I think Andre has given a really fantastic background on which to think about the role of radiation therapy in palliation. I apologize to those of you that are radiation oncologists that will know a lot of what I'm going to say, but pitching to a fairly broad multidisciplinary audience. Some people will not know very much about radiation therapy. Some people will know a lot. So I hope that people feel free to ask me any questions or clarify things. So the overview of my presentation, I'm going to talk particularly about the goals and principles of radiotherapy and palliation. Some of the indications for palliative radiation therapy. As Andres mentioned, these are, the palliation is very broad, not just about bone metastases, but for radiation oncologists, this is a very important part of our work, and I will discuss a little bit more about that. Also, some principles of clinical studies around palliative radiation therapy, and some of the changing paradigms which have meant that we have changed the way we think about using radiation therapy for our patients, and hopefully some take-home messages and some great discussion afterwards, I hope. So I think it's important to say what I'm not going to be covering in this presentation, because again, Dr. Andre has given a very good overview of the complexity of the palliative care team, how multidisciplinary this is, and that therefore I'm not going to actually talk at all about analgesics, co-analgesics, anesthetics, and surgery and other systemic therapies in palliation. I'm going to focus on radiation therapy, but again, not about any detailed techniques of radiation planning or technical trials. Similarly, details of SRS or SBRT I'm not going to cover. I think we could easily do a whole webinar on those topics, and also models for predicting prognosis in palliative care. So I really am going to try and stick to the principles, as was my brief. So for radiation oncologists, palliative radiation therapy represents around 50% of our practice in most countries. It was absolutely fascinating seeing the world map according to palliative care services, and I fully acknowledge that Australia is sort of way bigger than vast swathes of the rest of the globe in terms of the amount of attention put on palliative therapies. However, even in my country, relatively, there are still some important gaps in people accessing palliative therapy and even palliative radiation therapy. And a lot of that is about lack of awareness and education as much as funding and staffing. But we also need to remember, and again, this came out in the previous talk, that it's not just symptomatic patients not just symptomatic patients that need therapies. It's very important to predict who are patients that are going to need palliative therapies to prevent progression of symptoms and deterioration in their quality of life. And sometimes treating before symptoms develop not only have the economic and quality of life advantages that we've discussed, but can be very, very useful in delaying or making more effective therapies that come later. Optimizing quality of life is absolutely key. And I'd like to reiterate what Andreas said about the fact that we're talking about people that are not in the last few days of life, but to consider palliation for those that at the point of them not being able to be cured of their disease, however we like to measure cure. And palliative treatment decisions are often very complicated. I think when I was growing up as a training radiation oncologist, I was taught by many of my senior colleagues that, palliative radiation was pretty easy. Most people got, 20 and 5 or 30 and 10, 30 gray and 10 fractions. And now that's all been completely blown out of the water. And some of the hardest decisions and longest conversations that I have with patients and their families are actually about their palliative therapy. And sometimes making a decision not to give radiation therapy is much harder than a decision to give radiation therapy. So never is it more true that personalizing and individualizing treatment is extremely important in the palliative setting. So we're constantly in all oncology and not least radiation oncology, we're considering the issues of quality and quantity in our decisions about the use of therapies. But obviously, when we're talking about palliation, never has it been more important to ask the patient about what their goals are and discuss with the patient and their family what the objectives of treatment are and what their desires are, particularly towards end of life. Andre's mentioned that the lack of home services in palliative care, even in wealthy settings, we have way too many people that die in hospital against their ideal wish, but because we haven't got the home services available. So this really throws in the air this idea that we're trying to extend life, which is really what we're trying to do in the palliative setting. So again, like all treatments, we're in cancer care and in radiation therapy, we are balancing the toxicity with outcomes. So we might be prepared to accept some more toxicity as we are thinking about curing a patient. For instance, a young patient with metastatic testis cancer, we would accept a more significant risk, particularly of acute toxicity, but possibly even late side effects, to achieve a cure in that patient. But in general, in people where we're trying to palliate their symptoms and make people feel better, we can rarely do this and be improving their quality of life if we also increase toxicity. So it's very, very important to think about where the scales lie in balancing toxicity and outcomes with our treatment. I really liked this figure, which actually I took from this fantastic article that some of you might like to look up, which came from Hematology Oncology Clinics of North America. And Scott and colleagues thought about the indications and the other information that's really important when considering a radiation therapy treatment schedule according to anticipated prognosis, the goals of treatment, the importance of controlling the disease at a local area, and the local area could be an area of metastatic disease, the sensitivity of the tumour to radiation, the availability of other options for palliating that particular person, which again comes back to what Dr. Andrea said, the impact on delaying systemic therapy by the delivery of radiation therapy, and the logistical burdens to the patient and family, particularly with having to travel for radiation therapy treatments. And according to all of those parameters, we might tend towards a lower dose, or simple technique and lower fraction radiation oncology schedule compared to a more complex or longer schedule for palliation. And therein lies the complexity of making decisions about palliative radiation therapy. So I was just going to whip through some of the many, many indications for palliative radiation therapy, which come up within this article. And I've adapted these slightly, but these investigators organised the roles of palliation in a methodical way, starting with pain, which is obviously one of the most common things that we try to palliate with radiation therapy. And particularly top of the list would be bone metastases, including those involving a core compression, bulky nodal metastases, and bulky primary or metastatic soft tissue lesions. Neurologic symptoms from brain metastases, leptomeningeal metastases, or nerve root compression, or in and around the eye. Bleeding, which might include oozing from skin lesions or within the stomach or bladder, or from fungating breast lesions or the head and neck. Particularly in my practice, bleeding is very effective for treating incurable bladder cancers. Not usually is radiation therapy very effective for significant arterial bleeding, but sometimes a bleed where there's no other option might be well treated with radiation therapy, particularly, say, in the stomach. Respiratory symptoms, as you would all know, cough, hemoptysis and dyspnea, particularly from head and neck and lung primaries. So obstructive symptoms or compression, including core compression, as we've discussed, superior vena caval obstruction or other airway obstruction, dysphagia in the esophagus, and distal GI or GU obstructive symptoms. Not effective usually if you've got complete obstruction, for instance, of the urethra. Impending symptoms such as impending core compression or possible pathological fracture. And then other indications include, obviously in combination, usually in combination with other therapies, but in particular after surgical interventions, fixation of bone for imminent or actual fractures, vertebrectomy, laminectomy, even spinal cord compression, etc., decompression of brain mets in particular. So just a bit more about the treatment of bone metastases with radiation therapy. Even in this day and age, we still very commonly use simple, single or parallel opposed pair of radiation fields to treat metastases, and that's what we're seeing there in the left-hand picture on your screen. But we have the whole breadth of from very simple to very complex treatments for bony metastases. And so it's not easy to say that one size fits all. And we have to become very expert in tailoring all of those factors I discussed before in deciding on the appropriate treatment plan, going from something very simple to something very complex, such as SBRT or vertebral lesions. So again, I can't impress enough, it is very important to understand the nuances of individual patients, and that involves very good communication with the patients, as well as understanding of their disease process to work out the most appropriate treatment for them. And also coming back to what Dr. Andrea said, the importance of making sure that we rationalise our resources, even in high-income countries, but absolutely vitally important in lower-income and middle-income countries where we have huge gaps in the availability of radiation therapy and other palliative treatments and services. I draw your attention to this very, very good and recent summary, the ESTRO-ACROP guidelines for external beam radiation therapy for uncomplicated bone metastases. You'll see the senior author there is the guru of bone metastases from the UK. And in the global setting, really, Professor Peter Hoskin. This is a great summary of the indications and some of the literature around the use of radiation therapy in bony metastases. But basically, one of the main messages out of this work, and includes reference to this updated meta-analysis of single versus multi-fraction radiation therapy for bone metastases. This article was published a couple of years ago in the Green Journal. And they updated the meta-analysis about single and multi-fraction treatments. This was led by Ronald Chow, another guru in radiation oncology for bone metastases. And very, very important finding that can't be stressed enough, that all of the trials, when the data was combined, in all settings, a single fraction, usually 8 gray was the most common dose, compared with many multi-fraction schedules from between 5 to typically 5 to 10 fractions, but often more. The same pain response rate was achieved with a single fraction. All regimens achieved a fairly low toxicity rate, and the only difference in this data was that there was a higher retreatment rate for the single fractions. and retreatment rate, and that was statistically significant. About 1 in 5 patients required a retreatment, but the large majority did not. So really the outcomes from all the many, many studies that have been done, and one of the recommendations of that paper was that we didn't waste any more time looking at single versus multi-fraction schedules of radiation therapy. So from all those studies, the improvement of pain was somewhere between 62 and 80%. Complete response for non-complicated bone mets, in other words, all analgesics could be stopped, was somewhere between 24 and 30%. The duration of response was somewhat variable and was overall lower with for some people with a single fraction, and retreatments were almost always possible as long as constraints, for instance, for spinal cord, were respected. So this work has led to, in many countries, in particular in Canada and in Australia, in our part of the world, and notably not in the United States, largely related to the funding model, where there may be incentives to not adopt single fraction regimens. But in Canada and Australia, the notion of single fractions for bone metastases in the vast majority of patients has been written into the Choosing Wisely campaigns. And now some of you might not be familiar with that, but Choosing Wisely campaign, it's a mission to ensure that practice across many, many areas of medicine is evidence-based. And so within oncology, one of the quality outcomes for radiation therapy that was enshrined in those Choosing Wisely programs was that for clinicians, single fractions of palliative radiation therapy should be the standard of care, and that anything more than that was really not evidence-based and was wasteful. A lot of this is about preserving and appropriately expending resources in medicine. So I think that's quite powerful, and we actually measure that in our quality assurance meetings, that we still give a large majority of single fractions for radiation therapy. And this has obviously got high significance in less well-off countries. So what do we mean then by complicated bone metastases? We've talked about non-complicated bone metastases. Well, these are bone metastases that are associated with some other symptoms or clinical presentation. So spinal cord compression from malignant disease, bone metastases causing neuropathic pain with radiation into a dermatome from usually spinal nerve root compression, an imminent or actual pathological fracture in a bone. Bone metastases such as the one shown here, where there's a very large soft tissue component, and also in many cases retreatment of bone metastases wouldn't be considered simple. So in those cases we sometimes have to adopt different techniques or multi-fraction situations. I was involved with a large multi-centre study in Australia and New Zealand, also some British studies involved. And we looked at whether neuropathic pain was well palliated or better palliated with a multiple fraction regimen with 20 Gray in 5 fractions compared to a single fraction. Because as I was training, there was a well-known dogma, not backed up by clinical trials, that probably if you had nerve compression, you needed to treat with higher doses and with more fractions. So we put this to the test in this TROG trial. And in fact, we found that the response rates were the same for single fraction and 5 fractions in the neuropathic pain setting. The toxicity was very similar. Pain control was slightly more durable for 5 fractions, but not actually reaching statistical significance. And the cost benefit for giving a single fraction, and that was in 2005, so now, you know, getting on for what, 18 years ago, was somewhere between $800 and $1,500 per patient, and that wasn't actually including any hospital costs, inpatient hospital costs. So we can just see there an idea of the sort of savings we make by giving evidence-based radiation therapy. And so we now use this to justify giving single fractions, and if necessary, giving another fraction, but mainly single fractions for those with neuropathic pain. In fact, Peter Hoskin has also done some studies, led some studies, and for poor prognosis patients, single fraction for core compression is also equivalent to 5 fractions in terms of pain management and rate of maintaining ambulancy. Although if there's a large soft tissue mass or a longer expected survival, most people I think would give more than a single fraction, but I'd love to know what you do in Indonesia. So there's another companion paper, which I also encourage you, particularly people that are training in radiation oncology, might like to look up this paper, which is similar guidelines, but for patients with more complicated bone metastases. So those other presentations that I've mentioned, these are really, really good treatment summaries. So just a note on palliation with brachytherapy, perhaps more for the radiation oncologists in the audience. There is some good data about the effectiveness of palliation, particularly for obstructive symptoms. This is just a paper here, an example of measuring dysphagia with a palliative approach using brachytherapy. Similarly, there are studies for bile duct cancers and also for bronchus. A lot of services now don't have brachytherapy, but the conclusions of these authors was that brachytherapy was really underused as a very simple and often quite relatively cheap way of palliating some symptoms, and unfortunately it's a skill that seems to be we're moving away from in radiation oncology. So just a quick note on some clinical trials actually outside the non-bone setting. Obviously, it's critically important that clinical trials in palliative care, not just in radiation therapy, but across all disciplines, have some quality of life and patient-reported outcome measures. And the standard cancer endpoints really of overall survival or progression-free survival really become much less important. These are some trials that I actually have used the evidence in my clinical practice. So MRC UK bladder trial headed by Professor Jill Duchenne many years ago now showed that 21 in 3 fractions was a very good treatment regimen for controlling hematuria in bladder cancer, less so irritative symptoms. The Quartz trial, that was a multi-center trial globally, and we contributed some patients to, found that in poor prognosis patients, actually steroids and best supportive care and palliation was as effective as adding whole brain radiation therapy to that. So some patients, it's quite appropriate to just use steroids and withhold radiation therapy. A more recent one from our TROG group in Australia and New Zealand looked at radiation therapy alone compared to chemoradiation for dysphagia in esophageal cancer. Radiation therapy alone was equally effective and, not surprisingly, much less toxic and much cheaper than combined chemo-RT protocols. So just a couple of things that really are changing the paradigm for palliative radiation therapy, which again apply, I'm sure, to other disciplines involved with radiation therapy. But obviously the advances in our technology allowing dose escalation and better side effect profiles has changed the scene in terms of what we can offer. We have to be very, very careful though that because we have technologies and because we have fancy equipment in some places, we mustn't let this drive our decisions about the most effective and cost-effective treatments to give our patients. changing profile of metastatic disease in terms of better imaging techniques, more effective systemic therapy options, including chemo and immunotherapy and other therapies, has definitely changed the alternatives for managing symptoms in our palliative patients, and also made the presentations of late metastases quite different. I see a lot more brain and leptomeningeal disease in our prostate cancer patients that when I was first training, we never saw, because people are being kept alive for such a long time. We have the whole explosion of the oligometastatic phenomenon, which I'm not going to get into much detail here, but the whole idea of when is a patient curable and when are they on the palliative path has become a lot more complex in recent years. So it's often less clear and more difficult to predict prognosis, and also therefore the impact of potential late toxicities from our treatments. And brain metastases is the absolutely archetypal example of this kind of treatment, where since I was starting training in whenever the early 1990s to the current day, it's practically unrecognizable how we still treat a palliative condition, going from simple whole brain treatments, which still have their place, to very complex multi-targeted therapy with SRS, and sparing different parts, sensitive parts of the brain, as the radiation oncologist would be very familiar with. So it's really become extremely complicated. I won't talk about immunotherapy and radiation therapy combinations, but many of you would know that this is really changing the landscape in terms of our combinations, what we can expect to achieve with radiation therapy. And I think we just have to watch this space and continually keep ourselves upskilled as the other therapies that do and don't interact with radiation therapy become more commonplace, particularly in wealthier areas. Again, I'm not going to focus on SABR stroke SBRT, so stereotactic body radiation therapy for the non-radiation oncologists in the audience, but the idea that we can use very high doses to areas of metastatic disease has become a really new paradigm. And you go to any talk, any radiation oncology meeting, and there are many sessions on this topic. But I think we have to, again, stay very open to the use of these techniques and be careful that we're not overusing those techniques just because they're available, and not to be wasting resources using very complex techniques just because we can and we have the technology. The simple old school techniques are very effective and should still be used very much more commonly than our fancier techniques. So that's all I'm going to say on that at the moment. Perhaps we might have some discussion. So just an example, I've just looked at, what I was doing with palliative radiation therapy. I don't actually use much SBRT, but this is a man who is 75. He's very fit. He's had metastatic prostate cancer now for 9 years. He doesn't tolerate well castration with androgen deprivation therapies. He's been on Zoladex. It really impacts on his quality of life, and he actually still works. And so when we demonstrated that he had 2 small lesions, one in the sacrum that you can see here and one in his manubrium, we actually selected him as a candidate that might be suitable for SBRT. This area is getting 5 fractions 30 gray in order to maintain his quality of life by reducing the need for him to go on androgen deprivation therapy. So this is just a recent example for me of where He's not somebody that's dying imminently, but with his goal to maintain working and a good quality of life and not have the toxicities of ADT, this seemed like a good indication for SBRT. But as I say, not common in my practice. Very quick comment about dedicated fast-track palliative radiation therapy services that are becoming more commonplace around the world. Obviously, still probably the privilege of many of the wealthier countries, first conceived in Canada and now taken up around many places in the world, including Australia, often led by extra skilled advanced practitioner radiation therapists, and led by them. And what we mean by this is people that are diagnosed with particularly bone metastases is the main thing. They get assessed on the day, they've had their imaging, they have their radiation therapy planned with a simple technique at simulation, they have their treatment, and they can go home all in the one day. They can also be assessed for their pain control, analgesics can be adjusted, support services can be provided, and also social and psychological services can happen. So it can be a much more holistic and very much more patient-centered practice, which can actually save a lot of money, can save a lot of waiting list issues and prevent a lot of admission and a lot of morbidity amongst the cancer community. So you can read a bit more about that if you're interested in that paper I mentioned before. So finally, I think some important take-home messages. Decisions about palliation with radiation therapy and palliation in general actually are some of the more complicated things that I think we do as radiation oncologists. Very, very important that it is multidisciplinary as discussed, and it must be individualized. So it's really gone are the days where we decide for the patient what's right for them. Really important to understand patients' wishes and their goals, particularly in end of life. Just because you can treat is not a reason to treat, and we have to really justify the use of any advanced technologies at our fingertips. As I said again, I want to repeat that single treatments are often the most effective way to and the best way to treat patients. And rapid response services are something to think about because they can really be very beneficial for our patients. Thank you for your attention. I'd be keen to hear if people have questions, and I look forward to the panel.
Thank you very much, Dr. Sandra Turner, for a very wonderful talk. And we can learn so much from your presentation. I believe not just us radiation oncologists, but I hope that our friends from other disciplines here could also get useful insights of radiotherapy role in palliative cancer care in a multidisciplinary settings. So there's a lot for us to think about and to work on together with lessons learned from Dr. Sandra. And now we will begin our expert panel discussion. And for this session, I'm happy to invite to be co-moderating with Dr. Ben from IROS, our consultant radiation oncologist. Dr. Ben has just joined us back just a few months now after his 3 years work in IAEA Vienna. Please, Dr. Ben.
Thank you very much, Maya. And yeah, I agree. It's a very interesting talk this afternoon, very useful. And there are a lot of things to think about. I'm sure it's equally eye-opening to the other participants as well. Now we have been, I think the stage has been set here. We have been exposed to what is happening globally, what are the challenges, what are the situation, and what are the future directions. I think it's good to now take a look inside and discuss what we have today in Indonesia, what are the challenges, and what are our directions going forward. So for this panel discussion, we have several national experts. We have Dr. Siti, Annisa, Nuhonni, one of a leading figure in palliative care, and also part of the Indonesian Society for Palliative Care, I think, Indonesian Palliative Society. We have Dr. Pryambodho from the Indonesian Society for Anesthesiology and Intensive Care. Representing the surgical perspective, we have Dr. Derajat, former chair of the Indonesian Oncology Society and also representing the Indonesian Society for Oncologic Surgeon. We have Dr. Djumhana, a senior medical oncologist representing the Indonesian Association for Hematology and Medical Oncology. So we have a wide range of expertise here, and as Dr. Andre Ilbawi said earlier, palliative care is multidisciplinary, and it should be multidisciplinary. It should be integrated. So I think it's going to be very interesting to know what our first expert has to say about this, Dr. Nuhonni, about the current status of palliative care in our country right now. How integrated are we between hospital and community and between the different actors in providing palliative care services? And which way are we heading? So please, Dr. Nuhonni.
Yes, Dr. Ben, thank you very much, especially to Prof. Patti, Indonesian President of Indonesian Radiation Oncology. Also, thank you very much to Dr. Mayang and Dr. Andre Ilbawi and Professor Sandra Turner. I agree with you, Dr. Andre, that palliative care is the soul of medicine, as you have mentioned in your speech. To the organizing committee and to Dr. Andre and Dr. Sandra, allow me to speak in Bahasa Indonesia, but my PowerPoint is in English. Yes. My top is current status of palliative care in Indonesia. Yeah. Development and challenges of palliative care in Indonesia. Sejawat sekalian, saya akan menyampaikan dalam bahasa Indonesia. Semoga teman-teman semua menjadi lebih mengerti sampai di mana sebenarnya pelayanan paliatif di Indonesia ini. Jadi, Kementerian Kesehatan menyatakan bahwa 240.000 kasus kanker per tahun, itu 70% itu pasien-pasien tidak mungkin disembuhkan, dan ini memenuhi persyaratan atau definisi tentang perawatan paliatif. Dan pasien-pasien itu memang dalam kondisi yang menderita, oleh karena itu kita harus mempunyai respons, ya. Dan sejak 1992 di Indonesia ini sudah berdiri suatu organisasi yang disebut dengan Masyarakat Palliatif Indonesia, Indonesian Palliative Society. Dr. Derajat pernah juga menjadi ketua dari MPI tersebut. Dan kemudian apa yang dicanangkan oleh Indonesian Palliative Society ini mendapat respons dari Kementerian Kesehatan, sehingga pada tahun 2007 diakui dan ada SK Menteri Kesehatan tentang pelayanan paliatif di rumah sakit. Dan saat ini palliative care, pelayanan palliative care itu sudah ada di kota-kota besar, terutama kota-kota yang melayani rumah sakit yang melayani pasien kanker, karena memang kanker lah yang membuat inspirasi mengapa diadakan pelayanan paliatif, ya. Dan pada kenyataannya ternyata yang memenuhi persyaratan untuk seorang dinyatakan memerlukan perawatan paliatif itu ternyata tidak hanya penyakit kanker, sangat luas, nanti akan saya singgung sedikit. Dan tahun 2016 Kementerian Kesehatan telah mencanangkan suatu standar pelayanan paliatif kanker, dan tantangan juga ini terkait juga dengan government policy dari pemerintah, dan juga adanya kesenjangan edukasi terhadap palliative care itu sendiri. Tentu saja ini sudah dijawab dengan adanya kurikulum di dalam pendidikan tenaga kesehatan, dokter, perawat, dan sebagainya ya. Dan attitude dari healthcare professionals itu sendiri masih ada yang belum peduli terhadap pelayanan paliatif. Dan di Indonesia kita juga mengenal bahwa ada belum mengenal tentang perawatan paliatif itu bagaimana, dan bagaimana kita bisa memeratakan sampai ke ujung-ujung dunia di negeri kita ini tentang pelayanan paliatif. Di sisi lain memang pemerintah mempunyai peran yang sangat-sangat penting untuk pengembangan pelayanan paliatif. Oleh karena itu, melalui keputusan dari Menteri Kesehatan, maka Dinas Kesehatan di setiap daerah sudah harus memunculkan perawatan paliatif menjadi bagian dari perawatan yang harus ditangani oleh rumah sakit setempat ataupun dalam sistem kesehatan masyarakat. Ya, tadi saya sudah sebut bahwa para profesionals di bidang kedokteran terkadang masih berpikir bahwa perawatan paliatif hanya diberikan pada akhir dari perawatan seseorang yang tidak mungkin disembuhkan. Padahal WHO sudah menyatakan bahwa untuk kanker khususnya perawatan paliatif harus dimulai sejak dini, sejak diagnosis ditegakkan. Begitu juga dengan pendekatan psikologis, aspek sosial, spiritual, kultural, pendekatannya masih belum terasa menyatu dalam pelayanan kedokteran secara utuh. Dan sekali lagi, kondisi geografi Indonesia, pemahaman masyarakat tentang paliatif masih belum memenuhi. Nah, sebenarnya mengapa Indonesia memerlukan perawatan paliatif? Kita tahu bahwa life expectancy di Indonesia cukup tinggi, dan sebagian besar pasien-pasien kita yang menghadapi kondisi paliatif adalah pasien-pasien usia lanjut. Dan sekarang kita tahu ada peningkatan dari masalah kardiovaskular, malignansi, penyakit degeneratif, chronic kidney disease, HIV/AIDS, dan juga palliative care untuk anak, ya, dan juga negara kita adalah negara disaster. WHO pernah menyatakan bahwa kondisi disaster yang menyerang pasien-pasien karena bencana itu sebenarnya sebagian memerlukan pelayanan paliatif. Nah, data dari Kementerian Kesehatan tahun 2002 yang baru saja muncul, kita sudah melihat bahwa ada 4 penyakit katastrofik yang utama dan menyebabkan kematian tertinggi, yaitu penyakit jantung, kanker, stroke, dan gagal ginjal. Oleh karena itu, penyakit-penyakit ini pun menjadi suatu bagian yang harus kita antisipasi. Nah, dalam pengembangan pelayanan paliatif di Indonesia, kerjasama saling bertaut antara pemerintah, dalam hal ini adalah Ministry of Health dan Public Health Office, dan juga pelayanan kesehatan, hospital, puskesmas, ya, dan juga social organization serta community based palliative care merupakan suatu kesinambungan yang tidak bisa kita katakan begitu saja. Jadi dari hulu ke hilir ini berjalan harusnya dalam ikatan kerja yang erat. Nah, ini saya sampaikan beberapa contoh dari training modul yang sudah diterbitkan oleh Ministry of Health, dan ini menjadi panduan kita untuk melakukan pelatihan terutama kepada tenaga kesehatan. Dan Kementerian Kesehatan sendiri terakhir ini bulan Juni yang lalu telah melaksanakan pelatihan untuk 14 provinsi. Mudah-mudahan 14 provinsi ini dengan rumah sakit yang mengirim pesertanya saat ini sudah harusnya mulai bekerja untuk mengangkat pelayanan paliatif menjadi sesuatu yang istimewa. Sementara itu, Yayasan Kanker Indonesia juga melakukan pelatihan untuk para caregiver, dan ini tetap berlangsung sampai dengan sekarang. Di sini saya sampaikan sejak tahun 2015 sampai dengan 2022, Yayasan Kanker Indonesia bekerja sama dengan pemerintah daerah, bekerja sama dengan MPI, Masyarakat Palliatif Indonesia di cabang masing-masing, juga sudah melakukan pelatihan baik di Jakarta, Bandung, Semarang, Solo, Kupang, Jayapura, Makassar, Lampung, Palembang, Tanjung Pinang, Puskesmas di Jakarta, dan juga terakhir melakukannya di Manado. Dan saat ini sudah 30 kali melakukan pelatihan dan jumlah yang sudah dilatih adalah sekitar 2.353. Kita harapkan para caregivers yang sudah dilatih ini di seluruh Indonesia masih bisa aktif dan bisa berkolaborasi dengan puskesmas setempat sehingga layanan paliatif kita insya Allah tidak hanya pada hospital base, tetapi juga pada community base. Itulah yang bisa saya sampaikan. Dan sekali lagi, palliative care, an ideal environment for interprofessional education and practice. Bisa tidak, kita harus bergandeng tangan setiap profesi bersama dengan pasien dan masyarakat, dan juga keluarga pasien untuk menjadikan palliative care is the soul of medicine. Terima kasih. Assalamualaikum warahmatullahi wabarakatuh.
Salam. Thank you very much, Dr. Nuhonni. As you have described, there are a lot of things going on. Training, advocacy, even the establishment of the new Indonesian Palliative Society. I think those are really encouraging. So if I may ask, what do you think would be our biggest priority going forward over the next 3 or 5 years? What will be the biggest issue we need to address, or what will be the biggest opportunity we can take to improve palliative care?
Yes, Dr. Ben, education is very, very important. It's not only for the professional doctors, but also the allied health, the nurse, especially for palliative, and also the community. Now the community already know that the palliative care is not only in the hospital, but it should be in the community. So education for all part of the member of our country is very important about palliative care.
Thank you, Permis. Thank you very much for that. Yeah, I fully agree that education is currently lacking, and as you described, one of the reasons that palliative care is not integrated is because even healthcare professionals in oncology still have misconceptions about the role of palliative care and the timing for entering palliative care. Thank you very much for sharing your expertise, Dr. Nuhonni. We will move on to our next issue that was described by Dr. Ilbawi, which is lack of access to morphine and other pain treatment modalities. And we have here Dr. Pryambodho. Dr. Pryambodho, what do you think here is our biggest issue about availability of pain medication, and how do you think we can improve this?
Okay. Thank you for the opportunities. Talking about morphines and all opioids, I think it's a very big issue, a very big problem, not only in Indonesia, but I think in all the country, because we know that the amount of the drugs, the amount of the opioid is limited, and it's also drugs which has very full restriction and very full, special rules. Maybe I will talk in campur-campur ya, in mixed language. Jadi it's not easy to asking for more opiates, more morphine for a country. Indonesia, we know that the number of the amount of the narcotics or opioids that they used and for doctors in our daily service is very, very less than the truly needed. But we have already talked about it with the Ministry of Health and also the BNN, Badan Narkotika Nasional. But until now, there's no no solution. Sometimes we still have empty of the morphine or else. And in this pandemic, one of the distributors of opioid also got mereka menjadi tidak bisa mempertahankan perusahaannya lagi, bangkrut. Jadi kita kehilangan salah satu opioid dan itu membuat kita makin kesulitan untuk menangani. Tapi memang apabila ini bisa dipenuhi, saya rasa memang masalah fight dengan cancer pain itu masih bisa ditangani dengan baik. Dan cuma masalahnya adalah pada saat saya dulu mahasiswa kedokteran, seingat saya di primary healthcare they provide morphine. Tapi sekarang tidak, but not now. Saya tidak tahu kenapa kebijakan ini berubah. Apa karena memang jumlah opioidnya makin berkurang atau karena kesulitan untuk meregulasinya. Tetapi yang jelas ini membuat mengapa pasien akhirnya makin susah untuk mendapatkan cancer pain treatment yang memadai. Saya masih berhubungan dengan diskusi dengan adik dari seorang pasien yang sekarang membuat suatu RSCM dan bisa membantu teman-teman penderita kanker di daerah, dan saya mendapat cerita mereka di sana sama sekali tidak punya opioid. Jadi pada saat mereka mengalami severe pain, what they can consume only maybe paracetamol and paling bagus juga tramadol. They don't have a strong opioid there. Kasihan. Jadi memang aksesnya masih sangat terbatas. Di kota besar saja masih kekurangan, apalagi di daerah terpencil. Itu tantangan yang paling utama. Sementara kita tahu bahwa 85-90% dari kasus cancer pain itu bisa ditangani dengan baik hanya dengan pendekatan stepladder WHO. Boleh mungkin saya sharing sedikit. Jadi step WHO yang 3 ini, step 1, 2, 3 ini masih relevan dan itu bisa menangani mungkin about 85-90% dari kasus. Sementara kalau dengan opioid tidak berhasil, baru kita naik ke interventional pain management seperti nerve block atau epidural atau PC pumps atau others ya. Dan kalau menurut saya masih ada step berikutnya, itu surgical treatment seperti tumor removal, cordotomy, and else. Tetapi yang jelas untuk yang 3 step awal ini aja kita masih terbatas, apalagi step 4 intervensional. Belum seluruh dokter spesialis anestesiologi mendalami masalah ini untuk pain management. Dan kebanyakan teman-teman kami yang bermain dalam pain management di Indonesia seringkali biasanya menangani masalah untuk muskuloskeletal pain management dan bukan untuk cancer pain. Jadi masih sangat sedikit sekali yang menspesialisasikan untuk interventionalist in cancer pain management. Sementara radiasi juga saya yakin perannya juga banyak untuk mengurangi nyeri, tapi juga saya tahu bahwa tidak di semua daerah terapi ini bisa dilakukan, hanya di kota-kota tertentu saja. Nah, ini tapi untungnya hanya diberikan apabila tadi terapi narkotik tidak berhasil, kemudian efek samping opioid yang lebih tinggi ketimbang analgetiknya, atau memang ada comorbid pain. Nah, ini juga kadang-kadang begitu. Begitu saya seringkali mendapat pasien yang begitu dievaluasi ternyata yang dirasakan not truly the cancer pain related to the cancer itself, but the comorbid pain. Dan sebetulnya itu bagus untuk dilakukan terapi dengan interventional pain management. Pengalaman kami di RSCM sudah banyak yang kami lakukan untuk interventional pain management ini. Tapi dari sekian modalitas yang bisa dilakukan, sebetulnya dokter anestesis bisa berperan lebih besar lagi. Karena apa? Karena ada obat yang diberikan melalui neuraxial atau spinal, baik itu epidural atau blok spinal, single injection atau continue, yang ini harusnya bisa dioptimalkan di daerah yang ada dokter anestesinya. Jadi apabila ada pasien yang mengalami cancer pain yang hebat dan ya bisa ditangani di sana dengan 2 modalitas ini, sampai nanti kemudian kalau perlu dirujuk untuk terapi lebih lanjut ya silakan dirujuk ke kota-kota besar. Cuman sayangnya untuk epidural teknik saja kami sekarang sedang berusaha untuk mendata juga. Jangan-jangan modalitas ini di daerah juga sudah jarang dilakukan nih. Anestesia regional yang disebut blok epidural yang biasanya adalah salah satu teknik rutin untuk perioperatif, jangan-jangan sudah dilakukan, sehingga tidak heran kalau untuk terapi yang first step to after the door ini juga tidak bisa dilakukan di daerah. Pemilihannya nanti juga memang harus berdasarkan lihat prognosis pasien. Pada pasien-pasien yang life expectancy-nya masih lama, maka block neurotic dan implantable device di Indonesia kita barangnya sudah ada, tapi harganya cukup mahal, tidak masuk di BPJS. Apabila ingin memasang untuk yang intrathecal pump itu pumpnya saja 40 juta, belum untuk pasangannya. Saya belum tahu lagi apakah morfinnya juga sudah ada, karena morfinnya juga harusnya khusus karena dia harusnya pekat ya. high concentration. Dan untuk spinal cord stimulation, sekali lagi barangnya juga sudah ada, tetapi harganya bisa sampai 400 juta satu mobil sendiri. Nah, padahal untuk yang bisa dilakukan adalah anestesia simple, yang bisa dilakukan berulang apabila diperlukan, baik itu single shot maupun dengan extra catheter. Tapi yang tidak kalah penting ini sebetulnya, dan ini kekurangan kita ini. Jadi sudah dibuktikan bahwa faktor keluarga dan caregiver itu sangat mempengaruhi untuk penata laksanaan nyeri kanker. Dan kita masih menganggap mereka adalah sebagai klien yang tidak punya peran apa-apa terhadap nyeri kanker pasien. Padahal khususnya tidak. Keluarga, caregiver, dan bahkan pasien sendiri harus kita rekrut menjadi tim yang kuat untuk menangani cancer pain yang dihadapi. Jadi saya ingin menambahkan quote of the day. Kalau tadi Dr. Andre sudah mengatakan palliative care is all of us, dan personalized treatment is important by Profesor Sandra, saya mau menambahkan adalah create good teamwork with the patient and family is very important. Tidak hanya good teamwork di dokter, karena kita mungkin masing-masing disiplin ilmu sudah berusaha untuk menolong pasien, tetapi kadang-kadang koordinasi tiap hari tidak berlangsung dengan baik. Komunikasi tiap hari, daily communication between doctors, between specialists, is not very fluent. Jadi kadang ada beberapa masalah tentang cancer pain yang mungkin harus dikomunikasikan juga dengan spesialis onkologisnya, tetapi mungkin tidak tersampaikan. Atau mungkin kita juga berdiskusi dengan bedah onkologis, tapi tidak tersampaikan dalam praktek sehari-hari. Dan yang satu yang tadi juga sering terlewat adalah pasien dan keluarga yang sering kita anggap sebagai out of the team, tetapi harusnya mereka kita rekrut, karena sekali lagi ini adalah hidupnya pasien, badan juga badan dia yang berhak untuk menentukan. Apabila pasien masih mendapatkan kontrol untuk memilih terapi yang bisa dia dapatkan, itu akan membuat kepercayaan dirinya kembali dan berdampak baik untuk penanganan nyerinya. Demikian Dr. Ben yang bisa saya tambahkan. Terima kasih.
Terima kasih, Dok. Thank you, Dr. Pryambodho. So I guess that's just a depressing story, isn't it?
Yep.
We need to deal with a large number of patients who don't have access to basic cancer pain management. But at the same time, we are trying to improve availability of advanced pain management. And it seems that improving availability of advanced pain management seems to be easier than improving availability of basic pain management. I think that's quite ironic. Do you think stronger advocacy will make a difference? Who do you think should be involved in this advocacy for?
It's about the system. System is above us. It's the responsibility of the ministry, I think.
Yeah, multiple ministries should be involved.
Yeah.
Dr. Ilbawi, I think we will need to borrow your wisdom about this on success stories of countries who have successfully increased availability of basic pain management. So anyway, thank you very much, Dr. Pryambodho. That was very enlightening. Let's move on before we involve our experts. We also have Dr. Derajat representing the surgeons here. And I remember an aphorism that I once heard in a multidisciplinary conference led by a surgeon, that a good surgeon knows how to operate. A better surgeon would know when to operate, but the best surgeon will know when not to operate. Well, I don't think I'm not sure if this is still valid in view of palliative care. So I think I would like to invite Dr. Derajat to give some opinion about the role of surgery in palliative care, and probably also the role of surgery as a palliative treatment.
Okay.
Please, Dr. Derajat.
Thank you very much, Dr. Ben, Prayogi, and Dr. Mayang as the moderator. Firstly, I want to thank Professor Soehartati for setting up this very important webinar for us to open our mind, to widen our horizon in using irradiation in palliative care. Thank you, Professor Soehartati. And I also want to thank Dr. Ilbawi and Professor Sandra Turner to open our horizon also in your country and in the whole world, what they are doing, and so we can look back to us what have we already done and what we are going to do in the next future. Thank you, Dr. Ben. So this is a very important thing for me especially, because usually a surgeon is more egoistic and narcissistic, so they are seldom work as a team. They think that they are with their hands they can rule the world of patients. So it's not true. So I also remind me of what you think, that the good surgeon is know how to operate, but the best surgeon is he knows when not to operate. But the other speech from Scotland surgeon, he is a philosophical surgeon. He says that a good surgeon treat the disease, but a great surgeon treats the patient that has the disease. It's impressive for me. Maybe it will impress you too. Okay, Dr. Ben, I will open my slides. I will share my slides. Give me a moment to screen share. Okay, so in my mind, there are no good or strong guidelines based on an evidence base. That's Professor Turner says on her speech. I agree, fully agree with that. But behind that, we have to have a good patient selection guideline. So we are using that guideline to decide when we operate or when not to operate. So we have also how good communication within the team itself, and some things that already approved by Dr. Blake Cady. The tumor biology is a very important thing. So we have to lean on that. We have to rely on the tumor burden or tumor biology to select the patient. Patient age, severity of symptoms, and extent of the disease have also to be considered. In the field of surgical oncology, tumor biology is king. The patient selection is queen, and the technical maneuvers are the prince and princesses who always try but usually fail to usurp the throne. That's Blake Cady says in his the Archive of Surgery in 1997. It's a long time ago. He already think about that. So the basic principles of the surgical oncology is we have to focus on the quality of life, maintaining good symptoms control, and this is the most important. The holistic approach takes into account the person's life experience and current situation, because every patient are individual and every patient are different between others. A care that compasses the patient and those who matter to them, including support in bereavement. An open and sensitive communication to the patients, the carer and colleagues. This is much more important than a surgical technique. And respect to the patient autonomy. This is also have to be very considered. So communication is the most important thing, I think, in palliative care. How to tell the bad news to the patient. So we have to be honest to the patient, but without destroying hope. That's a tricky thing. The informed consent, education of the patient's family, the patient has the right to know, because sometimes the family comes to us and tell us to not to tell the patient, but we have to think, we have to remind that the patient has the right to know. And as a clinician, we have to be patient on patient's rejection. I want to share with you the patient's point to us, the clinician that treat them. This is the saying of Anatole Broyang. He is one of the editor of the New York Times. He says, to the typical physician, my illness is a routine incident in his rounds, while for me, it is the crisis of my life. I would feel better if I had a doctor who at least perceived this incongruity. I just wish he would give me his whole mind just once, be bonded with me for a brief space, survey my mind as well as my flesh, to get at my illness. For each patient is ill in his own way. So we have to remind this, and as a clinician, we have to almost always think about this. So in the surgical oncology, the palliative care is, the surgical technique is an important thing, because they have very much studies that says that if the treatment is, the patient selection is good, and the treatment, surgical treatment is doing the best, so it will prolong the survival and also relieve the symptoms. So we have several studies, big studies with thousands of patients that gives this evidence. So the summary, goals should be the patient-directed and discussed early. Palliative surgery should be considered after patient symptom control, resolution of improved quality of life, minimal morbidity and mortality, modest resources utilization, and the surgery with curative intent can be undertaken in the palliative care setting if the disease-free interval is more than 12 months, the former status is less than 3 in the ECOG status, optimized nutrition, and complete resection. So we need better define palliative surgery. What is palliative surgery? And we have to establish the standard of our own in our country. I think that is what I can share with you, Dr. Ben, Dr. Mayang, and everybody. I hope.
Thank you very much, Dr. Derajat.
Okay.
I think that was excellent. A lot of pearls of wisdoms we can take from there. And I also realized that the role of the surgeon extends beyond the tumor itself, but also in palliation of symptoms like obstruction, and even as Dr. Pryambodho mentioned, pain control. I think we will see even increasing importance of surgery in palliative management in the future. Thank you very much for that.
Okay.
So thank you, Dr. Derajat. Shall we move on to Dr. Djumhana now? We also know that the picture of palliative care in patient spectrum is blurred now with the increasing arsenal of options we have for treating the patient, and sometimes the line between curative and palliative treatments are becoming unclear. And at the same time, the costs have been increasing. I don't think the cost has ever gone down. So I would like to invite your opinion, Dr. Djumhana. How should we approach this issue about value in our treatment for patients?
Okay, thank you very much, Mr. Chairman, Dr. Ben Prajogi. Welcome home. You're still in Geneva or already here
in Jakarta? Already in Jakarta, though.
And Professor Soehartati Gondhowiardjo, thank you very much for your inviting, and welcome to Dr. Andre Ilbawi from WHO and Dr. Sandra from Radiation Oncology from Australia, and also from the previous speakers from Dr. Nuhonni, and then also from Anesthesiology, and Dr. Rajat. How are you? So long time to see. Okay, so thank you.
Dr. Djumhana, can we see your face?
Okay.
It's a pity that we could only see the top of your head.
You see my...
Thank you very much.
Okay.
Yes.
Yeah. Okay. Sorry. So can I share my slides, please? Okay. Yeah. Okay. Okay. So, kelihatan nggak? Do you see my slides?
Yes, we can see it.
Okay, you can see.
Bagus, Dr. Djumhana.
Terima kasih, Rajat. Okay, thank you very much. And you know that if we start with the treatment of the cancer, so you have to determine the goal, the tujuan, and also the treatment modality we are choosing, because sometimes people confuse about the goal and the modality, the treatment modality. Yeah. So bahasa Indonesia saja ya, oke. Kita harus membedakan antara tujuan, goal, curative, goals, or palliative ya, treatment. Sedangkan bentuknya, manajemennya, modalitinya, main modality atau modalitas utama, and supportive treatment and palliative care. You know, so we have to discriminate between palliative treatment and palliative care. However, so even though we have curative goals in treatment, either by surgical procedure or radiation, or as well as by systemic therapy, so every treatment modality needs supportive treatment, and also the supportive treatment also are required by the palliative care as well. So therefore, in palliative treatment, we can call it as the surgical palliative, and then radiation palliative, and systemic therapy palliative, systemic or chemotherapy palliative, etc. Treatment. So I am focusing on, so okay. So referring to already by previous already mentioned by the previous speakers, WHO, kita lihat sini bahwa prevention relief suffering untuk palliative care, untuk yang sini sejak Desember 4 2019, untuk yang mengobati terutama pain tadi dari Anesthesiologi sudah mengatakan bahwa pain ini harusnya menjadi nomor 1 karena kebanyakan pasien stadium lanjut dan nyeri ini, namun demikian memang kondisinya sangat-sangat memprihatinkan. Yang kedua adalah physical, psychosocial, and spiritual. Since the first time we built Dharma Cancer Hospital, Dr. Nuhonni already led the team of palliative care team in Dharma East Hospital, and up to now she's still active. Ya betul ya. And in the past kita palliative care adalah spesifik. Sekarang adalah prinsip palliative really expressible pada pasien kronik ultimately fatal ini tadi sudah diterangkan bahwa dari anestesiolog bukan hanya smart cancer tapi juga yang lain-lain untuk yang Dr. Nuhonni mengatakan tadi untuk yang penyakit stroke, penyakit kardiovaskuler, penyakit HIV dan sebagainya. Dan oleh ini interdisiplin team, physician, nurses, occlusion dan lain-lain sebagainya tadi sudah disampaikan juga. Ini adalah palliative care. Ya. Nah sementara yang akan kita katakan akan kita angkat adalah mengenai treatment modalitas, yaitu bahwa ada surgery, radiation, dan systemic therapy. Maaf itu radiasi hilang. Jadi masing-masing terapi semi, terutama systemic therapy ini menyebabkan efek samping. Dan efek sampingnya ini because of the side effects of the systemic therapy, either cytotoxic chemotherapy or even targeted therapy, even though we expected first that target therapy give less side effects. However, real world show that it also the same side effects appear caused by the targeted therapy, as we can see in cytotoxic side effects. Okay, and sekali lagi curative, we hope that patients cured, sembuh, curable treatment. Sedangkan paliatif adalah tidak akan sembuh. Namun demikian, yang penting adalah complication, nyeri-nyeri itu berkurang dan quality of life-nya akan meningkat. Jadi kita tetap di dalam hal kita pembedahan, radiation, terapi sistemik ini ada side effect dan supportive therapy ini memegang peranan. Nah, obat-obat sistemik terapi yang bisa menimbulkan efek samping semua, ya. Tidak betul bahwa targeted terapi lebih sedikit efek samping, enggak, malah lebih berat, lebih banyak lagi, lebih hebat lagi. Karena apa? Karena targeted terapi dia adalah reseptor yang bukan ditemukan pada sel yang normal, tapi di semua sel tubuh kita yang sel kanker, tapi juga di semua sel tubuh kita yang normal juga ketemu. Akibatnya efek sampingnya lebih berat, ya. Begitu juga imunoterapi, sistem imun kita sudah terganggu. Biologic terapi juga sama dengan efek sampingnya lebih hebat. Jadi terus terang aja bahwa tidak betul bahwa targeted imunoterapi, biologic terapi akan memberikan less side effects compared to cytotoxic chemotherapy. No, so they also give the same side effects, sometimes worse. Okay, nah ini febrile neutropenia, fatigue due to anemia, bleeding, problems, nausea, vomiting, mucositis, diarrhea, anorexia, cachexia, pain, bone metastasis, neurologic complication, dermatologic complication, etc., etc., can be caused by the disease itself, the cancer itself, and by the due to the treatments, side effects. Okay, so that's why I think percuma saja. Okay, it's no use if you only give the patients with cytotoxic chemotherapy or systemic therapy without considering about the supportive treatment to prevent and to treat the complications due to the side effects of chemotherapy. So otherwise, the patient will die of the side effects of the systemic therapy, not due to the disease itself. Jadi pasien bisa meninggal karena efek samping dari penyakitnya, dari obat-obatnya, bukan karena penyakitnya hilang, ininya juga hilang, ininya juga hilang. Jadi oleh karena itu bahwa obat-obat tadi untuk supportive treatment, baik untuk yang nausea, vomiting, thrombolysis syndrome, dan tentunya adalah merupakan tujuan daripada supaya tujuan pengobatan kita yang tujuan kuratif bisa diselamatkan. Begitu juga untuk paliatif juga kita akan bisa memberikan, tapi sekali lagi paliatif juga timbang, you have to consider about the risk and benefits of the targeted therapy, etc. If you are considering to give the patients as a palliative modality. Okay. Jadi, nah pada solid tumor kita tahu bahwa pada early stage locally advanced survivalnya compared to advanced metastasis adalah lebih tinggi, ya, dibandingkan dengan advanced metastatic stage yang not curable. Namun kita bisa menggunakan palliative treatments, for example stage 4 lung cancer. So we can give the patients with gavitin, tyrosine kinase inhibitor, and the patient can survive. My patient can survive more than 10 years, 12 years, and the patient died because of COVID infection. Okay. Begitu juga pada blood cancer, acute leukemia, bone marrow transplant akan bisa menyebabkan sembuh, bisa bisa menyembuhkan sembuh. Namun demikian pada kronik myelogenic leukemia atau leukemia kronik adalah BMT allogenik bisa dikerjakan, tapi efek sampingnya berat, pasien bisa meninggal pada saat diberikan transplantasi allogenik. Oleh karena itu maka imatinib yang merupakan obat targeted terapi tyrosine kinase inhibitor bisa tidak menyembuhkan, tapi namanya palliative treatment, bisa hidup sampai pasien kita sampai di atas 20. Nah, untungnya obat ini lebih ringan, gejala efek sampingnya ringan, namun kita terus monitor di dalam hal apakah pasien ada efek samping ataupun apakah relapse lagi. Begitu juga myeloma multiple, dia adalah bortezomib, bone marrow transplant, kemudian untuk palliative not curable. Nah, oleh karena itu maka kita akan kenal namanya continuum of care. Ya. Continuum of care pada metastatic tumor, terutama yang awalnya adalah pada metastatic colorectal cancer, dari satu yang sudah stadium 4 yang sudah meta ke paru atau hati, di samping di operasi sinkronus atau makronus juga diberikan terapi targeted terapi dari first line ke second line ke third line sampai bisa bertahun-tahun. Nah, begitu juga tadi LGK, imatinib kalau tidak berespon, kita bisa ada yang second line, nilotinib, third line, ponatinib, sampai dia long term. Jadi ini adalah survivalnya, menyebabkan survival makin panjang. Ini adalah namanya bukan palliative care, tapi palliative treatment. Jadi, namun demikian, efek sampingnya bisa menyebabkan pasien juga mendevelop derajat efek severe. Soalnya kita memberikan supportive treatment. Jadi selalu ada supportive treatment. Obat chemoterapi sitostatika yang sejak tahun 1998 sampai sekarang memberikan efek samping yang berat sehingga perlu terapi suportif. Begitu juga target terapi ini pada stadium 4. Kita tahu bahwa pada stadium 4 diberikan obat-obat targeted terapi baik pada breast cancer untuk trastuzumab, dupilumab, ataupun pada metastatic colorectal cancer, bevacizumab, cetuximab. Survivalnya bisa tinggi, namun demikian quality of life akan jelek kalau kita tidak berikan supportive treatment. Begitu juga obat-obat dengan small molecule inhibitors untuk yang paru, stadium 4, kemudian pada breast cancer dengan dosiklib, itu bisa menyebabkan kelainan jantung, olaparib juga sama, bisa menyebabkan efek samping yang berat. Nah, oleh karena itu survival akan tinggi kalau quality of life-nya baik. Nah, bagaimana quality of life ini bisa? Begitu juga obat yang lain, imunoterapi, pemilzumab, pemilzumab, ataupun terapi hormon bisa menyebabkan gangguan efek samping yang bisa menimbulkan pasien quality of life jelek. Oleh karena itu maka baik pada pembedahan maupun radiation maupun kemoterapi kita perlu adalah supportive treatment, dan supportive inilah kita akan berikan pada pasien-pasien dengan patient palliative care juga akan berikan supportive treatment, terutama pain. Yang kedua adalah yang lain-lain, nutrition dan sebagainya. Oleh karena itu saya kira yang paling bagus adalah kita bahwa supportive treatment bisa digunakan pada curative goal. Supportive treatment bisa dilakukan pada palliative care, bukan hanya obat saja. Supportive itu bisa juga tadi dikatakan nutrisi, kemudian support psikososial dan sebagainya, bahkan untuk yang religion dan sebagainya kita perlu sekali untuk memberikan support. Dari saya demikian kira-kira. Terima kasih.
Thank you, Dr. Djumhana. Before we move on to our discussion, because Andre has another meeting right ahead, I think if you can still spare 5 minutes with us, Andre. We have unearthed several issues with palliative care in our country. I hope you could get the message, even though some of the discussion was in Indonesian. We particularly have issues with integration of the services and also integration of different stakeholders. And I think this shows its ugly head in availability of pain management nationally. Aside from that, do you have any other advice for us?
Thank you kindly, Dr. Bennett. And before continuing, I just want to pause and appreciate the amount of work that has been done, the leadership that each of you have shown. The panel really has provided a level of insight and clarity that is remarkable. So thank you for sharing this important information. What I see and what is very common in situations like this is a lot of strong individual or smaller scale efforts. So we see clarity in how to establish treatment standards, as we heard so well from our surgeon colleagues. We see great insights into the experience of people who have palliative care needs, as we heard from Dr. Siti. What I think is important is how can we develop a broader agenda, a shared agenda. So there are two mechanisms that could be considered as a next step, Dr. Ben, and thank you also for your leadership in this. One is to find what is the right platform for collaboration. This can be done through professional societies. So IROS can take a leadership role and convene other professional societies in developing, let's say, practice standards. That could be an entry point to address what we also heard, which is a common experience, which is the competencies of providers, not only the oncologists. So ministries of education, of course, changing national standards is difficult, but if they have the weight of a network of professional associations that are coming to say, we want these competencies to be embedded in primary care or in specialty care, it adds the visibility, adds the prioritization. So professional societies can help with what I've heard as a major challenge, which is competencies and how to embed those competencies. The other mechanism by which that can be done is through university hospitals or through cancer centers that come together and say, we are going to develop a new program for postgraduate training or in-service training on palliative care, and they share that asset amongst the different hospitals or cancer centers. So that is one opportunity, is to build a shared training program for in-service training. The second thing that I've heard quite a lot of, and this is very common, one of the participants had raised it as well, and thank you, really, the participants have been asking important and challenging questions. One is, as we've heard, the readiness to take on palliative care as part of a dialogue with people who are presenting with late-stage disease, because there is a hope when individuals come that the discussion is curative intent, and then palliative care only comes, as we heard, a very difficult example of someone who had advanced rectal cancer invading the bladder, and that's not the right time for, of course, palliative care is needed, but it's part of the first dialogue with the patient and with the family. This is not easy. It requires a cultural shift. So this is where we need better community engagement. And I know we have many advocates on the call today. It is important that we bring people who were diagnosed with cancer to the table and say, what's the best way to communicate, introduce the topic of palliative care at this point. And here again, IROS, each of you as leaders in the community, you can convene a national dialogue with the Ministry of Health that invites people to share the lived experience of someone who has cancer and ask, what are some standards for communication that could be improved? We've seen this in countries where they have embedded the professionals that are needed for palliative care discussion into the workforce from day one through a national decree or through a national training program. Those, for me, I think, are the two biggest pillars. What you also have in Indonesia are, you have many important research findings, and we heard some of that from the panel. So I would also advocate for data collection and also for advancing a research agenda, where I think the experts on the call today can make major progress in advancing that. So those would be the three major pillars. One, how to develop shared training material, because often we see just ad hoc, one hospital, one professional society, one community activist. How do we do it more systematically? Training. The second is, again, how do we change the culture around palliative care? And then the third is to really build that multidisciplinary culture in each hospital as a starting point, and using research as an entry point for that multidisciplinary dialogue. Given the leaders like Professor Tati, who are on the call, and the esteemed panel, we know that the government may be taking interest as part of a health sector dialogue. It is also important, go to the government, each of you, you are a strong voice in the cancer community. So please also, as a step one, brief the government on this call, on this webinar, on the series, and see if you can use that to bring government involvement in day one, because that ultimately will result in the broadest changes that can be achieved. But really, thank you for the opportunity to speak. I have been humbled by such an incredible group of experts to share perspectives, and thank you to the participants and for the questions as well. Thanks, Dr. Ben, back to you.
Thank you very much, Dr. Andre. We really appreciate that you set aside some time in your busy schedule to share with us today. Thank you very much.
Thank you. Thank you, really. It's always a joy to connect with the dear colleagues from Indonesia. I will say just one more time, I said this on the last IROS call. Part of the reason we joined from headquarters is because the world is taking notice of Indonesia. You're doing many things very well. So we join you because we want to be your champions. We want to be at your side and learn from you, because many countries are watching what Indonesia is doing. So congratulations, really, and I look forward to the next time we can greet each other. Thank you again.
Thank you very much, Dr. Andre.
Thank you, Dr. Andre.
Okay, now I think we can start discussing the difficult questions that we face as clinicians. I tried to allude to this question earlier. It is often not easy for us to let go, as some of our panel members have described. Letting go and just accepting that it is no longer our effort to cure, but it is our intention to improve the quality of life. It's often difficult, not only because we approach this issue too late in the management of the patient, but also sometimes because the available options are limited. Like, for example, availability of pain control, which is difficult. And that leaves us with, difficult decisions to make, whereas deciding on palliation seems to some of us as if it's the same as abandoning the patient. So we all know that this is not true, but I would like the opinion of our panels here, Dr. Nuhonni, Dr. Pryambodho, Dr. Derajat, Dr. Djumhana, Dr. Sandra Turner, and we also have Dr. Dia Martina here. What do you think? How can we make this process easier? What can we improve to help our fellow clinicians on the ground making this difficult decision in palliative care? I will leave anyone who would like to give the opinion first. I will leave the floor open.
Can I say my opinion, Dr. Ben?
Please, Dr. Pryambodho.
Yeah, I think before we make our decision as the doctors, we also have to see the side from the perspective of the patient and the family. I think it would help us and make some more important information that can be used for us to make decision. Because maybe we have think our plan too far beyond their expectation, but maybe their expectation is very, very simple. What they want is very simple. Maybe they don't want a very sophisticated technique or everything. They just maybe want to be, for example, to be close to their relative or something like that, while they understand what they are the disease or the malignancy is. But on the other hand, it's common in Indonesia that the family is still closing the information about the disease to the patient himself. So the patient didn't know that he got cancer, or she doesn't know that he got cancer. And it's make us difficult also to make a decision in medical terms. So I think what I've said before, it's important to make a good team between doctors and also the patient and the family, and to open every information to them and also to us. And let's gather all those information and find what our aim is now. What is our target for the patient, especially the patient target, not only the doctor's target. And that's my opinion, Dr. Wayne.
Thank you very much.
Okay,
I think that's very interesting.
Dr.
Oh, Dr. Djumhana, is it? Oh yeah, please.
Okay. Yeah. Thank you very much for this opportunity to share our what is it, our suggestion, or etc. As a, as clinician, we have to tell the communication between the doctors and the patients and the family of the patient, and also not only the father and the mother or the daughter, but also the big family, and then the fund sources. Okay, the institution who will pay the treatment. Okay, then second one, we have to, in communications, we have to tell everything to the patients. And then, however, the most important thing that we have to give a best clinical practice, treatment to the patient, based on the evidence base, etc. And then the availability of the expert and the facilities as well. And then especially in our field about the medications available here, and then and access to the health insurance system. Then we have to tell the truth, frankly, to the patient. However, and then we have to tell honestly. Okay, we have to tell everything about the benefits and the risk, and then the possibility of the survival, etc. And if we go to our our neighboring countries. Okay, so every clinician will tell the patients in the screen of laptop and say, okay, this is what we have, and then this is, if we give them these medications, what is the expectation of the survival, and then the side effects, etc. And then and if you go to Australia, when the medical team will lead us to go to the theater room, to the ICU, intensive care, and then to the ward, in ward, and then every points of the patient will be involved in the treatment should be told to the patient, and then the most important thing that I think we have to give. It is a patient preference. Okay, the patient and the family have to decide what they have to give. And then now about the survival, the survival and the treatment. Okay, if you will give this patient blah blah blah, I think you can get the survival. And then we have to determine. We have to decide it. We have to determine. Okay, this patient are suitable for systemic therapy or not suitable for systemic therapy, or we have to put this patient into the curative treatment or palliative treatment. Then we have to tell the patient frankly, truly. And then if the patient still that, oh, I want to go to Singapore, I want to go to Hong Kong, I think it is and I think they deserve to have it. Okay, don't stop what they want to go. When what if the patient with the cancer, they desperately will try to seek to find the best medication for them. And then, however, so I agree with the concept of the palliative treatment, and not only the treatment from our sides, etc., but also what the patient and the family needs. Okay, not only for the education, for the treatment, etc., and then for the for social aspects, or what is it, the psychological aspect, and then also for and then for religious aspect. And then I think we have to see the patient as holistic. Okay, holistic, not only for what is it what you call it, as
not just the disease.
target people, but it is a human. We have to give this division a holistic approach, which include the body, the mind, and then the system, the organs, and then the soul, and then the religion, and then the family, and economy, education, etc. That's all. Thank you.
Thank you, Dr. Djumhana.
Holistic
so I think,
yeah.
So I think this is encouraging that both Dr. Pryambodho and you have emphasized the importance of dialogue, a clear and honest dialogue between the doctor and the patient.
Communicate.
I think that's wonderful. And while we are at the medical oncologist side, I would like to invite Dr. Dia Martina. What do you think? How can we integrate better along the journey of the patient management and make transition along the different phases easier and avoid overtreatment, of course.
Thank you very much, Dr. Ben. Thank you very much for the opportunity, Professor Tati, Dr. Mayang. Thank you very much, Professor Turner, and also all the panelists. I learned a lot from the session from you. Before I answer Dr. Ben's question, maybe I want to pick up from the last Professor's statement by two of our panelists and also Dr. Andre actually about culture, about our specific culture, where commonly we not disclose the bad news to our patients, especially when family requests that. And as what Dr. Djumhana has already shared, that is really helpful. Dr. Djumhana, thank you very much. There is also a new framework that is recently published about how to address cultural dilemma of breaking bad news, and that is what we know about breaking bad news. But this is most of the time we don't get to that point. Most of the time we need to ensure the family who ask for non-disclosure, and this is the steps. First, you need to acknowledge the request. For example, by saying, we understand that you have asked us not to tell your mother about her diagnosis. We would like to talk with you about this and to understand your perspective. The second, build the relationship. When you ask us not to tell her diagnosis, what is on your mind? Are there particular things that you are worried about? What is she like as a person? What things do you feel are most important to her? Number three, find a common ground. This is the most important step, find the common ground. We can, for example, we already received information from the patient, from the family. Find the common ground and state it. For example, we can appreciate from what you have said that she is, for example, an anxious person. Your priorities are for her to be as comfortable as possible and not to be put under mental distress. These are the goals that we share with you. And then we move towards honoring patient's preference and outline to the family about the harm of non-disclosure of information. For example, by saying, many families ask us not to tell patients about their diagnosis. As in your case, it is because they love their relative and are worried about them. However, we need to recognize that most patients want to know their diagnosis. We need to honor that choice if she would like to know. When patients understand what is happening, they feel better, physically and mentally. They feel more connected with their family. They are able to be involved in choices about their care. If we try to hide diagnosis, patient often feels alienated and will eventually find out the diagnosis in an unsupported way. And then the fourth one is provide emotional support and respond to the concerns. For example, we say that when we break bad news, we take care to do it sensitively. Your mother can always choose not to know her diagnosis, and we will check if we have her permission before starting the conversation. We will do it gently and in stages, giving her the opportunity to ask questions and to have her feelings and perspectives heard. The last is devise supportive solution. Together with family, we need to make the next step. Now that we have discussed the situation, we need to make a plan of what to do next. We feel that it is important that we now tell her what is going on. What are your thoughts? So that would be, I think, potentially important resource or materials that I have shared, that I can share.
I think that is very valuable. I will definitely look up the material.
Dr. Ben, can I comment on Can I comment on this?
Please, Dr.
Okay.
Djumhana.
Yeah, I agree with you, Dr. Diah Martina, about the way or how to deliver, okay, the diagnosis of of cancer to the patient, because it completely different between AIDS patient, HIV patients, and cancer. If in AIDS patients, so I think the first, you have to tell first to the patient first, okay, not to the family, and we have to ask the patient, okay, can we tell to the family? They will say that no. So I think we have to appreciate to the patient in HIV patient. However, in cancer patients, I think it depends on the patient characters, something like that. I think we have to tell first to the family, okay, and even though to the family or to the husband or to the wife or even to the daughters, but you have to first you have to tell them first, okay, not the patient first. Can I tell the patient directly, or the family of the patient can tell the disease to the patient, or maybe there is a very close friend, or maybe a religion what is it, the religions, the religions leads, religion leaders, okay, something like that, to tell the patient, because but however, I think most of the patients usually wants to have the information directly from the doctors, okay. However, maybe it is a very difficult point for us, okay, when we tell the patient directly, when we have to tell via family, etc. Maybe this is the very important and very difficult point to.
Okay.
Yeah.
Yeah. Thank you, Dr. Djumhana.
Thank you, Dr. Djumhana.
Yeah.
I totally agree.
Dr. Turner, may I ask you about your experience with your nationwide campaign of advocacy? I think there was a campaign of several videos and meetings as well for radiotherapy, but I think it expanded more than that.
Yeah. So targeting cancer, we call it.
Targeting cancer, that's right.
Yeah. So that was, it still is, a campaign to raise awareness of radiation therapy and the role of radiation therapy in all aspects of care, because even in Australia, people that might benefit from it don't receive it. And obviously that is the same across pretty well all the parts of the world except the US. So it's a public campaign by our society, and it's on social media, lots of videos and information, an information-rich website aimed at patients and carers. Also, I was thinking before when you're talking about sort of educational goals and embedding them into other professions training, we have a whole program for GPs, bringing them into the radiation oncology centre so they can understand what radiation therapy is like for their patients. We run events, we make resources, and one of our big messages is about the vital role of radiation therapy in palliation. We have lots of case studies and stories about people benefiting from that to try and get people to understand. And the other thing we're starting to do is to embed programs to make sure that all medical students learn specific key points about radiation therapy. But I think that you could make the same case for including these competencies around palliation. And this is happening in our society. So in our oncology block, where the students come into hospitals, they see cancer patients, they now have to come to a palliative care clinic. They have to come to the radiation oncology centres. So it means that all doctors, wherever they go within medicine, end up having at least some basic understanding of these areas in cancer, which they wouldn't have otherwise had. So it's good to target the trained professionals, but I think also getting in at the university level is somewhere else that you could focus some educational goals, even if very minimal.
Thank you very much, Sandra. So time is limited, and there is a reason why we call this a series, because it's not I don't think it's not possible to discuss everything, all the different nuances in palliative care and palliative treatments in just one webinar. Yeah, so we have identified several interesting topics to be further explored in our next webinars as well. And personally, I'm really looking forward to the next sessions and learning even more about this. But for today's session, if I may summarize our discussion, we have learned that palliative care should be integrated. Some of us already know that it should be integrated along the spectrum of patient management, the patient journey from diagnosis as early as possible. But turns out it also needs to be integrated across different levels of the health system, across ministries, different stakeholders. And I think this is a big homework for us all. We also have, I think, reached a consensus that shared decision-making based on an honest and clear dialogue of the goals of care, outcomes of different options, value to the patient's health is very important. Also for quality of life. It's very important in making the decision for palliative treatments and also transitioning to palliative care. And the earlier this is done, the easier it will be. And especially in limited resource settings, we have discussed different challenges that Indonesia faces. But I think it's clear as well from the different presentations that prioritization is very much needed everywhere in the world, although most importantly in limited resource settings. And this prioritization will require a very good understanding of the value of different options, avoiding over-treatment, but also avoiding under-treatment is not easy. So I think these are our learning needs for the future, different homeworks for every one of us present here. And with that, I would like to return the session to Dr. Mayang and Professor Tati.
Thank you very much, Dr. Ben. Wow, it has been a very remarkable session. So yes, we're now way past our schedule. So I would like to invite Professor Tati as our president of IROS to give the closing remarks for this session. Please, Prof.
Sorry. So thank you very much for all fellows, colleagues, for your participation today. We have many take-home messages, as we heard from Dr. Ben from this session. We should think about this all, reflect, and then get back together. And most importantly, we should synergize what should we do together. As a clinician, for example, we need to be more careful now. And is our modality is the best to give for to our patient? What is the patient wishes? Is, as Sandra have mentioned, and is there another choice for them, maybe more cost effective? Maybe it can be prove a less struggle for the patient and her family. And let's not put our ego ahead, as it is mentioned by Dr. Derajat, of our patient benefit. And also it's important as the whole system, we need to establish a strong situational analysis in our nation. Where are we now? And as Andre has said, our next step is to assess our own situation and then organize the system to build a strong palliative care. This should be carefully done. All of our discipline and also involving our friends from the government, civil societies, and as Dr. Pri also captured nicely, including our patient and their family in our team, to think together and act. And now, are we ready? Will you join us? Of course, the answer is yes. I have a short story. When I was a fellow, it was the end of 19. I was a fellow in Bedson Oncology Center in Glasgow. Maybe some of you know that center. And I followed a very famous professor in the clinic. And at the time came a lady with a sarcoma somewhere. I could not check all the status of the patient, but the patient have a very good performance status. And seems that all the treatment that can be given were already given to the patient and were not give a good result, the disease is still progress. And it was very also shocked me. And the professor can say that I'm so very sorry that now there were no curative treatment for you. We can just give you a best supportive care. That's my story, what I heard when I was young, and it was very still in my heart. So let's give our best attention and hard work to improve the palliative care. There are still a lot of homework for us. So thank you very much for all of you, and we hope that to see you again soon. Thank you, Dr. Mayang.
Thank you, Professor Tatin. Thank you, everyone. And with that, we close our session. Looking forward to welcoming you again in our next series of palliative care. Thank you very much. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam.
Waalaikumsalam.
Thank you very much, Sandra. Thank you. Thank you.
Jadi potret dulu dong bersama dong.
Oh iya, potret lagi
bersama
lagi,
dulu
Dr.
dong.
Mahesa. Iya.
Okay, kindly please turn on your video, Professor and Doctor. I will assist you in taking pictures. Okay. Oh, Dr. Ando, please turn on. Okay, 1, 2, 3, smile. Okay, maybe one more time. 1, 2, 3, smile.
Yeah.
Okay, thank you so much. Thank you, Professor and doctors.
Terima kasih.
Terima kasih
Terima
semuanya.
kasih. Ya Pak Derajat, terima kasih.
Pak Derajat,
Terima kasih, Prof. Dok.
Terima kasih,
Pak
Bang.
Unjum,
Dokter.
Pak Unjum,
Oke,
apa kabar?
Hani apa kabar Hani?
Sehat
Hati,
ya.
oke Ben, Maya.
Dia apa kabar?
Ya, terima kasih, Dokter.
Alhamdulillah, Dok.
Lagi.
Terima kasih,
Baik,
Dr.
Ayo.
Mayang,
Ya,
dan Dr. Pryom.
Makasih, Dok.
Oke.
Makasih.
Oke.
Kita pamit ya,
Pamit
Pak
ya.
Dokter.
Terima kasih semuanya.
Mohon
Terima kasih
izin.
banyak.
Assalamualaikum
Terima
warahmatullahi
kasih.
wabarakatuh.
Sehat-sehat semuanya.
Iya, Dok.
Amin.
Makasih.
Terima kasih, Dr. Ben, Dr. Mayang. Saya end webinarnya.
Makasih, Mahesa.
Terima kasih, Dr. Mesa.
Ya, selamat sore.